All right, good evening, everybody. This is MacKay Jimeson. I'm with Patients Rising. I want to thank everybody for attending our town hall tonight. We have a packed agenda with a lot of guests and a lot of substance to go through. So we'll be really focused on, using the time well, trying to provide you with a lot of information. We're going to focus a lot on state policy tonight. You may be asking, why state? It's like kind of the end of the year. We got an election coming. The reality is, states are a funny beast. Every state has their own legislative session. A lot of states are part-time legislatures, and many are run roughly 4 to 6 months through the year. And so we wanted to kind of get a head start because there's a number of important issues that are happening at the state level. And so this is kind of a primer, if you will, on some key topics that we think are going to be core patients issues as we head into the 25 legislative session. So just to give you a quick overview, we're going to focus on safe repair of medical devices. We'll talk a little bit about upper payment limits on prescription drug affordability boards, and then we'll get to charity care reform. As always, we do deeply care about your questions. Feel free to insert them in the chat, and then at the end, we'll also have sort of an open Q&A where if people want to uh, go live, we can arrange that as well. That sounds like a plan. I'd like to turn it over to my good friend, our co-founder and chief mission officer, Terry Wilcox.
Thank you, MacKay. Hi, everyone. Welcome tonight. I'm very excited to be moderating our first panel, which is about the Safe Repair Act and right to repair, as it is often called as well. We've been working on this issue for quite some time at Patients Rising. And, what we hope to accomplish here tonight, especially for, the mission at Patients Rising, is we talk a lot to patients. Obviously, we're called Patients Rising. So this is a very important issue for patients to understand. In fact, all of the issues we're talking about tonight can be somewhat complicated for patients, and this is a real opportunity for us to share that. So thank you all for joining us tonight. The initiative that we're talking about tonight is dedicated to enhancing and protecting the safety standards of more than 24,000 medical devices that our healthcare professionals rely on to treat our loved ones. And so we're going to be talking a little bit about the safe repair of those this evening with two of our esteemed guests. Kick it off with my friend, Peter Pitts. Peter is president and co-founder of the Center for Medicine in the Public Interest. He is a former member of the United States Senior Executive Service and Associate Commissioner of the U.S. Food and Drug Administration. Peter is the lead author of many professional peer-reviewed articles and publications, including The Lancet, Health Affairs, the New England Journal of Medicine, the New England Journal of Medicine Catalyst, my apologies, Vaccines, Nature Biotechnology, Therapeutic Innovation and Regulatory Science, The Patient, and the Journal of Commercial Biotechnology. He has also served as the adjunct professor at Indiana University School of Public and Environmental Affairs and Butler University. Welcome, Peter.
Thanks, Terry.
And we also have joining us Dr. Rosalyn Layton. Dr. Layton is a leading international expert on technology policy and serves as a senior vice president of Strand Consult. She is also a visiting researcher at Aalborg University in Copenhagen, Denmark. Dr. Layton has extensive experience in the software analytics, finance, and advanced technology industries across Silicon Valley, India, and the Netherlands. She served on the president-elect transition team for the FCC and has been featured in prominent media outlets such as the Wall Street Journal, U.S. News and World Report, Forbes, and the Washington Post. Dr. Layton holds a PhD in business economics from Aalborg University and an MBA from Rotterdam School of Management in the Netherlands, and a BA in international service from American University. What a mouthful and what an impressive credentials you have, Dr. Layton. Welcome.
Thanks. So nice to be with all of you. Good evening.
Thank you. So we're going to kick it off tonight with a few, my first questions. I have questions for each of you individually, and I have general questions. So I'm going to start with one of the general questions, and whoever takes it first, then we will alternate. How does that sound? So the first question, and you can both have an opportunity to ask these first few questions. So even if you don't go first, you can chime in. We'll treat it as a conversation. So last month, World Patient Safety Day highlighted a critical theme for our healthcare system, improving diagnosis for patient safety with the slogan, "Get it right, make it safe." In the context of medical devices, what are your thoughts on the responsibility of healthcare providers and companies to prioritize patient safety above all else?
Well, I'll jump in. If a piece of medical technology isn't safe, it shouldn't be used. And if a healthcare professional doesn't know how to use a device safely, they need to learn. But relative to the right to repair debate, quality is the glue that holds technology together. And if we decide to trade safety, and that means we do away with accuracy, which means we do away with efficacy, which means tests give you bad results. And not only does that have a significant implication relative to costs, but when you're getting the wrong test results, your health not only doesn't get better, it can get worse. So it really is recognizing, Terry, to your point, the priority. If healthcare technologies don't work and then don't work for the patient, what else are we talking about here?
Exactly. I know patients feel the same way. Dr. Layton, do you have anything to add to that?
I can only agree. I think it's I think this is the when I don't want to preempt your next question, but what does this mean within this larger movement around right to repair? So I maybe you want to I have my thoughts on that, which is what I'm ready to share.
Wonderful. So, as you said, it's important to acknowledge the commendable arguments supporting this movement. Key points include that increased access to device repairs benefits both consumers' finances and the environment. Do you agree with this perspective?
So,
I'm sorry, go ahead.
So I have followed this policy issue for some time and have been on the different state circuits and listened to the arguments. And it's interesting because there is a sort of we know in technology policy and open access movement, in part it's driven by consumers have experienced a numbers of years of inflation and that they're looking for ways to economize. We understand that. But what I'd say is within this movement, there are self-interested actors who are looking, unfortunately, to preempt or free ride on others' innovations. And that is a concern to me, being a technology policy person, that we want to ensure the incentives for innovation. And so, for example, we have in our economy, in our society, our constitution, ability to license technology. We want to reward innovators for their innovations. So we have fair and reasonable, non-discriminatory regimes. If in fact you use the right to repair regime to get access to proprietary information, then you can basically leapfrog that technological process, and someone else gets to profit off of your developments. So that's my concern here, because those sort of things undercut the way that this is supposed to work. And we actually have legitimate regimes to get at technology in a fair, reasonable, non-discriminatory way. And so I'm here to try to let people know to be careful about the self-interested actors who may take advantage of the process. And in the end, maybe put consumers at risk. And certainly we could be putting patients at risk as well.
Yeah, I mean, I'll pick up on that. Obviously, right to repair covers a whole swath of types of technologies. I'm here to talk about medical technologies, and I'll tell you that right to repair, FDA-regulated medical technologies is a fatal attraction. Hospitals want to get things done on the cheap, but you can't trade cost for quality. You need people who are regulated by the FDA, who recognize what that means, who the FDA can identify to fix these devices. I mean, let me put it in perspective for you. So these groups are called independent service organizations, ISOs. I call them medical healthcare chop shops because they're not licensed. People don't know what they do, and the FDA has no line of sight into who they are. The FDA said the other day that there are about between 16,000 and 21,000 non-licensed, non-FDA regulated people that want to get into your MRI machines, your electrocardiographs, your ventilators, defibrillators. When you need these things, you need them right away, and they better work, and they better give you the right results. So, relative to the broader issue on right to repair, there are a whole host of issues, IP obviously being at the very top of that list. But there have to be carve-outs both at the state level and Senator Warren is trying to get stuff done on the federal level. There have got to be carve-outs for certain types of technologies, and medical technologies regulated by the FDA, at least to my mind, are at the top of the list. The FDA said, and I quote, Designing devices to limit access is a key component of ensuring a secure medical device. This is the FDA saying this. They know what they're talking about.
Thank you for that, Peter. I always tell from a personal standpoint, as I've written a couple of times on this, but just in my life, my uncle, for a living, he worked for he worked for Kodak, then he worked for J&J, but he repaired blood machines for a living. And I can't tell you the amount of training and updates, and he would go away for weeks at a time, like in manuals and all that. So, I mean, it is very extensive. And so to think that you can just open up, to your point, Peter, a chop shop and start
You're right.
going at it, I think it's,
Rosalyn made a really good point. It's like, who are the hidden actors here? Who's behind the curtain? And I'll tell you, when these machines go south, serious adverse events happen to patients. Full stop. Who does the hospital call? Who does the FDA call? How do you even find these people? So it's not surprising that a group of people who are pushing right to repair are tort lawyers, the trial bar, because they're looking for the deepest pockets. And I'll tell you right now that when an MRI machine doesn't work because it was fixed by an ISO chop shop, that one unit business is not going to get sued. The manufacturer of the original product is going to get sued, and they'll go out of business, which means less technology. People will want to invest in technology less and less because the liability is so high. It's not as simple as it sounds.
Can I just add on to that? I'm riffing here with what Peter's saying, talking about, and he will know this from the FDA, if you're to service the machines, the servicers don't have to follow the FDA quality system regulations. And that's a real risk there, because, talking about your father who'd spent all of his time working about the blood machine. But just in this last month, there was a cyber attack in a UK hospital, which brought it down for 40 minutes, which had been facilitated through a contractor. Not saying that the contractor was malicious, but it was a vulnerability that the contractor system had brought into that hospital. So that meant the surgeries had been interrupted. All of the records couldn't access records for the 40 minutes. All of the, everything basically went offline for that period. And it's a terrible situation when that happens, when that's going on. And the hackers, those who want to create disruption, they know that they can get maximum impact by going after a hospital. And they are looking for every vulnerability, whether for ransomware attack or zero-day attack, because it's not just data that you're going for. You want to create damage of hurting people. You want to create political instability. You want to have embarrassment, all sorts of things. And the hospital is the most target-rich environment. It's an absolute attack surface if you want to do damage. And it's one of the most critical infrastructures in America, perhaps the most vulnerable.
And around the world. I mean, I guess, the key point here, Rosalyn, is that, these are unintended consequences of good faith legislation. They're unintended, but they're not unpredictable. We know exactly what's going to happen if this type of legislation goes through. From the FDA perspective, right now, right to repair is illegal and dangerous, and it's hard for the FDA to track it. If these pieces of legislation go forward without, carve-outs for medical technology, it becomes dangerous legal activity that's exponentially more difficult to track, and that is not progress.
So thank you for that, both of you. Since we're doing a state town hall, my next question leads us right into that, which is, this year we saw over 30 states across the country propose their own version of right to repair legislation, with just a few of them receiving governor signatures. Now, do you anticipate that right to repair will become a more prominent issue in the 2025 legislative session for states?
I think that it will. It's populist. It sounds like the right thing to do. It doesn't sound like there could be any danger there. You've got the tort lawyers in the back pushing it forward, relatively with a lot of aggressive activity. And so what's going to take to make this really gain some sanity is a lot of shoe leather. Those of us who are involved in these programs are going to have to go visit state capitals. We're going to have to talk to state legislators. As MacKay mentioned earlier, not all state legislators are 12 months a year, every year. Some are biannual. Most are only part of a year. It's going to be hard, and it's going to take a lot of work, but it's absolutely worth the effort, because to Rosalyn's point, if we allow open access, if we invite in cyber attacks, if we can degrade the quality and the outcomes of what these devices and technologies are supposed to do, the patients are going to lose faith in these technologies. And that would just be a crime.
So Peter, on that note, from the FDA's perspective, what do you think the best path forward is for right to repair?
There has to be a carve out for medical technologies. You want people tinkering with MRI machines and electrocardiographs. What next? These technologies are enormously complicated. Now, obviously, every technology has a degree of a complicated nature, but these complications can lead to human death and despair for children in neonatal wards. For adults who need emergency surgeries. If the data that we're getting from these machines isn't accurate, if the machines don't work at all, we're back in the Stone Age. And I'll leave it to Rosalyn to talk about the cyber attacks. That isn't science fiction. That's happening right now. And if we allow people access to these machines, it's going to just race forward to a very bad future.
On that note, Rosalyn, how can right to repair legislation balance the need for consumer access to repairs with the protection of intellectual property and safety standards, particularly in industries like ours, which are healthcare and technology?
So what I would like us to take some encouragement from other industries which have addressed these issues. Within this sort of technological policy and regulatory domain, we have concepts of a general purpose technology and specialized technologies. And a good regulatory system and a good policy has the ability to discern the level of risk. And our historical US policy has done that. We have areas with light regulation and others with more prescriptive regulation because of the risk and the proven outcomes. So, for example, we can understand there are general purpose technologies which should be fine for right to repair, albeit that, other industries may be concerned about the hidden actors. But absolutely in the technology policy domain, and most critically in medicine, we have controls and standards. And medical devices are absolutely in this category because of the sensitivity for the patients, whether it's the safety, the cybersecurity risk, the personal data risk, the misuse, and so forth. These have to be controlled, and because of the adverse outcomes, we've seen it, we know what it means. You can't get that life back again if the person is harmed. So, my father was a surgeon. He worked with burns and trauma, and his maxim was prevention is always better than treatment. So when you're dealing in the world of accidents, you can't go back and undo the accident. It's always better to prevent the accident. And we know that in medicine and with patient safety, that's the area where you want to prevent. You don't want to fix it after the fact. You don't want to mitigate it. You want to absolutely prevent it. So when we talk about policy, the leaders need to understand there are things that have no connectivity to it, maybe no electronics, no problem. Go for your right to repair. But when you're talking about when a human life is at stake or the patient health, it's a connected device in a health environment with access to software, with access to a larger network, that should absolutely not be able to have these kind of open access requirements. I want to say one quick thing. I can tell you where, there are open access regimes that may work in general purpose technologies, but we have data that shows in areas where intellectual property is involved, we have degraded incentives for investment. So the other thing we need to be aware of is for those innovators, we need to have them invest, inventing in devices. This is a disincentive for them. They will look at other geographies, or they'll look at other kinds of ways to put their energies. So I want to share that in a big picture, because we know open access is not it doesn't go hand in hand with investments and having the best and quality technology. Those kind of incentives are at opposing ends.
Yeah, and Terry, to the point about talking to whether it's a state legislator, whether it's talking to Senator Elizabeth Warren in Washington, this is not a one-size-fits-all proposition. We all want to lower cost and we want to increase access for everybody, but not at the expense of quality. H.L. Mencken has a great quote, I paraphrase, where he said that for every complex problem, there's a simple solution that's wrong. And applying right repair across all technologies is a wrong step. And medical technologies, I think, is at the top of the do not mess with this list.
Well, thank you very much to you both. That's such great insights on this, and I hope everyone in our audience today got some great info from that. And if anyone has any questions, please feel free to put those in the chat, and we will get to those later. I am ending, MacKay, almost right on time. So thank you. And I want to mention before I kick it back to MacKay, if you want to visit the website, www.saferepairproject.com, you can find out more information, or you can contact us directly for any additional questions or assistance for the 2025 legislative session. So you can find a lot of information there at that site. And I will also put the link in the chat for everyone. And now I'm going to kick it back to MacKay to discuss upper payment limits and prescription drug affordability boards.
Thanks, Terry, and thanks, Rosalyn and Peter. It's great to hear your voices, and we appreciate you sharing your expertise on this topic. Yeah, and just a reminder, please, if you have questions throughout, feel free to pop them in the chat. We will do our best to get through them one by one. We obviously have some questions to try to drive the conversation, but we want to hear from you as well. I'm really excited to introduce two women who they're kind of kindred spirits to me. They're I think a little bit edgy, a little bit rebellious, and they get things done, which I really appreciate. I'm going to introduce Amanda Boone, who's co-founder of Cystic Fibrosis United, based in Colorado, and Naomi Lopez, who is head of Nexus Policy Consulting, and has also worked in the think tank space and in the policy world for a number of years, just to name a few, Goldwater, Cato, and I know I'm missing a ton along the way, but really savvy policy person. So today we're going to talk about this trend that's emerging across the country around upper payment limits and prescription drug affordability boards. Naomi, I'd like to start with you, because this jargon of sort of upper payment limits, I don't necessarily even know if I know what that means. So would you mind just kind of giving a little bit of an overview of kind of what is that term and what are the policies associated with that? And, how are these caps kind of being implemented at the state level?
Yes, thank you so much for having me tonight. And before I jump into your question, I just want to say I'm really honored to work shoulder to shoulder with patient advocates. I think that you guys are the most important part of getting legislation across the finish line. I can go in and do a PowerPoint or testify, but when it comes down to it, lawmakers want to hear your stories. No one can tell your story better than you. It doesn't have to be perfect. It doesn't have to have a lot of numbers in it. But you being there is what absolutely matters. And I'm always so touched and moved by the generosity of the patient advocate community, who they themselves are facing enormous financial energy, just trying to keep their family together and going. And yet they're so generous to help other patients along. So it's always just a privilege. So the reason that upper payment limits are so dangerous and are something that absolutely need engagement is because states have enormous authority over the practice of medicine and over the regulation of what's available in a state. And so when you think about, Congress, of course, Congress matters and they have a lot of authority too. But when you take a look at what's happening at the states, when they're moving these bills, when they're advocating for these unelected, unaccountable boards to be able to determine what the maximum price that anyone in the state can pay for medicine, they're giving a lot of control to bureaucrats and taking it away from you and your doctors. And that is why this is so important. So these bills have been passed in a number of states. Colorado, where Amanda is on the front lines every day, is the most famous example, but it's also been vetoed. It's been vetoed in Virginia. It's been vetoed multiple times in Wisconsin. It didn't make it out of the starting gate in Michigan this past session. But what I will tell you is that when legislation is introduced in the state, it will be replicated, and other states will try to pass it. In 2025, you can expect to see a lot more activity proposing and moving forward on these prescription drug advisory boards. What's also happening simultaneously is that under President Biden's Inflation Reduction Act, you've got 10 medicines that were put on up for negotiation under the Medicare program this year. And Enbrel and Stelara, which Amanda, we can talk about Colorado dealing with that, were 2 of the 10. There will be 15 more for the next 2 years after, and then 20 more medicines for the years after that. So if you can imagine, states are now looking at these lists. That is going to be their default list for what is going to be facing potential recommendations for upper price limits. And it's going to be incumbent upon patients to talk to lawmakers, to educate them, and let them know that it's not acceptable to take those decisions out of the hands of patients and their doctors.
So many in our audience, I think, are familiar with the Institute for Clinical and Economic Review, ICER. In many in our community have actually been involved in ICER reviews and things like that. The interesting thing about ICER is their reviews are important because it can have an impact on insurance decisions, but they're not a government body, right? They're sort of a nonprofit, sort of a convening body of academics. The big difference here is we're starting to see sort of an ICER-like model at the state level. Is that right? And what type of authority do these boards have?
Did you want Naomi, or are you?
Yeah, the follow-up for Naomi, and then
Okay,
we can go
sorry.
to Amanda.
No worries.
Well, unfortunately, a lot of the legislation that we're seeing really is missing some important elements, like establishing what kind of recourse a patient would have should there be an upper price limit, and that medication becomes inaccessible to the patient who needs that medicine. But I think that there are also important questions. So the quality of adjusted life year is a measure that ICER uses to establish whether or not a medicine is worth it. And unfortunately, it is appalling, and that they basically say that if you're disabled, if you're elderly, if you're not mobile, that your life is worth less than someone else's. And the idea that an unelected, unaccountable board would have that authority and a patient would not have recourse is absolutely appalling. So that is, we know that QALYs have been banned in the Medicare program, and there is federal legislation to ban them more extensively. They need to be banned at the state level as well. But this is what they're using to decide the fate of patients. And even if you don't have a medicine that affects you personally, because there's going to be, this is just the beginning. They will not stop until there are price controls determined by these unelected bureaucrats to decide who should get treatment. And the bottom line is that what they really want is they want to pay for low-cost treatments for everyone and not pay for more expensive treatments for those patients, leaving them vulnerable and without options. And I think that, some important questions for patient advocates to ask along these lines are why are rare patients being excluded from these boards in the first place? Why aren't QALYs banned? Who is getting the savings of these supposed cost savings? What's the recourse for patients? And most importantly, are lawmakers going to be participating in this? Are they going to be subject to the same price controls or upper payment limits as the most vulnerable patients in society?
Yeah, thank you, Amanda. I definitely want to bring you in here. You're a member of the cystic fibrosis community. You live in Colorado. Colorado's probably been the most aggressive, certainly the most notorious state in the nation as it relates to these prescription drug affordability boards, and it's impacted you and people that you know personally. Can you just talk a little bit about, I think, first just kind of lay out what is going on in Colorado as it relates to the prescription drug affordability board, and then specifically as it relates to cystic fibrosis? Can you talk a little bit about what happened there too?
Yeah, so I just want to say thank you too for having me. And I know, Naomi, while you were talking, I was nodding because I'm agreeing with everything you're saying regarding rare diseases and quality quality adjusted life measures that are just not appropriate for patients like myself. So I do have cystic fibrosis, and our drug, that our life-saving gene modulating drug, that when I say that, I mean it is a drug that came out in 2020, so not that old, that corrects the genetic, actually it was 2019, the end of 2019, sorry. It corrects or attempts to correct the genetic makeup in my body. So it's the first drug that treats the actual disease and not just the symptoms. So the CF community had it was our miracle drug. A lot of us, most of us were completely changed our lives. It was not uncommon for someone who was debilitated and disabled to now be able to work. It was not uncommon for someone who was leading towards lung transplant to avoid that. So I actually was one of those people that was an end-stage CF. I was in the hospital in and out many, many times on oxygen, IV antibiotics every other month. And I was being evaluated for a lung transplant right before this drug came out. This drug saved my life, and it also improved my quality of life. It also raised my lung function. So I do still have CF. It's not a cure, but it's the closest thing that this community has ever seen. It brought tears to all of our eyes. When I talk about it, I get emotional. So when the Colorado PDAB put our drug up for review, there was no warning or notice. All of a sudden, I was on the phone with my pharmacist, and we were talking about one of the copay assistance programs that I'm in. We were just talking about some of the nuances of that, and worrying about patients having access to different drugs. And he said, this is coming at the same day that the Colorado PDAB is reviewing your drug, Trikafta. And I said, what are you talking about? And he's like, well, they're putting up your drug for review to find out if it's affordable or unaffordable, to where they might place a UPL, or he explained it to me as a price cap on your drug. And I said, okay, isn't that not a good thing? I don't know. No, for him, it was not a good thing. He was worried that he would not be able to dispense my medication should a UPL be placed on the medication. That shocked me, sent me through a world of despair, fear. I didn't know anything about this PDAB. I had never heard of it. I hadn't heard it from my doctor's office. I hadn't heard it from the CF Foundation or other patient advocacy groups. It was a shock. So when we went to these reviews, it was very hard to navigate the reviews. It was hard to get on these meetings that were hours long. It was hard to engage with the board. They would not engage with us at all. So it was a fear that we had because of the fact that this is the one medication that treats our disease in this type of fashion, the only gene modulating drug. And if it were to go out of the market of Colorado, the state of Colorado, a lot of us would in fact die. We would get really sick and die. I don't even know how to, it was a painful experience. A lot of us have a lot of trauma from the experience.
Thanks so much for sharing that. And I want to, I have a few follow-up questions for you, but first I just want to kind of make a statement that this kind of irks me just in principle, because I'm very much a believer in the model. I'm not saying the way that we discover, develop, bring drugs to market, make them available to people is absolutely perfect. But I do believe that this idea that you have scientists, investors, inventors, companies coming together to bring treatments to patients, and the reward for that is to have some exclusivity on the market for a period of time, and then it becomes a gift to society once that period of time's over. And the idea was, we accept a little bit of that higher price as sort of the reward for success, but also knowing that the cost offset will be there in the long run, right? And it's really, my frustration getting on soapbox is the affordability challenges and access challenges that patients face are really a function of poor insurance, or insurance not living up to its end of the bargain here. But in this case, you're talking about a drug that's 5 years old, maybe on the market for 5 years,
Right.
and already you have a body of people questioning whether or not it's properly at the right price. That's to me, that's kind of baffling. I don't know if you have any comments on that, or I'm happy to.
Yeah, it was shocking to all of us. A lot of us were still in a state, we had not recovered from the trauma of not having Trikafta and losing the people we did lose in our community. I mean, I can't count how many people I knew and were friends with that have, sorry, my son was being loud. Sorry about that. Have passed away or didn't have their chance to have Trikafta. People in other countries that because their countries are not, they're not innovative like ours. They died waiting for this drug. Some of them still do not have access today, 5 years later. So yeah, we were all having to wrap our heads around and trying to justify our lives to this board of people that don't know anything about the drug chain, anything about how long it took us to get this drug, or about the blood, sweat, and tears that went into trying to even have a manufacturer invent a drug for us. I mean, there's only 30,000 of us in America, maybe 500 in Colorado. So they're saying, we're trying to save Coloradians money, but there wasn't that many of us in the state. So we were confused by that statement, that blanket statement. And not to add insult to injury, all of us have access to the medication. My copay is $0, mine. And then we polled the other patients in the state to make sure, this was lining up, and no one pays more than 50. I think the highest was $75, but most people pay under $50 a month for this medication. So we were confused at the first meeting. We were like, are you trying to save us money or are you trying to save the state money? And they weren't being transparent about that.
And can you tell me who is this board? Like, who appoints them? Who made them? Who put them in charge? Like, what's their expertise? Like, how are they able to make these decisions?
I guess they were anointed by God. No, I'm just kidding. They weren't, but the governor appoints them. So there was no election, there was no choosing them. And there is a family practice doctor on the board. There is two pharmacists. There is there's a professor, oncology professor, and they do have some specialty in their own diseases that they, are familiar with, but none of them per se have specialty in rare disease. So for instance, at one of our very early on meetings, they were trying to wrap their head around our drug. And one of the board members asked what an orphan drug is. Now, for the general population, I understand most people don't know what an orphan drug is. But for somebody who decides on something that could potentially make me lose access and make me sick and be back at the hospital and going towards lung transplant, or not getting a transplant and dying, and you don't know what an orphan drug is, like that really concerned me. And so they don't have a great grasp on what each drug is and how they affect people. They also kept saying there were therapeutic alternatives to Trikafta. There is not. So they were confused because in the past, other modulators came out that were eligible for some different mutations, but they did not have the efficacy level that Trikafta has. They weren't the miracle drugs that Trikafta is. So they were comparing those, but I'm actually a patient. I think it's 230 patients in Colorado that wasn't even eligible for those modulators. I am only eligible, my genetic mutation is only eligible for Trikafta. So I kept telling them, this is not accurate. This is not accurate, but they would not take it. They would not take it out of their review.
Do you think they're open to, patient involvement? Are they interested in patient insights? Are they wanting to understand the patient perspective in this? Or
They
maybe it's a work in
weren't.
progress.
Yeah, they weren't. They are now because we forced them to be, but they were not. So I think with the glaring thing was that they didn't contact us, right? I mean, I did a simple Google search because I'm like, okay, if you're not in the CF community, how quickly is it to find these doctors? So I did a quick Google search, CF, Trikafta, Colorado. One adult pulmonology clinic and one pediatric for cystic fibrosis patients in Colorado. It's in Denver, Colorado. It would have taken one quick phone call to their social worker, because we do have a clinic type approach with a disease like ours, which is complex. We have multiple providers and multiple different resources. It would have taken one phone call to them to say, hey, how do we reach these patients? How do we find them? We were not told by them. We were not told by anyone. I think it's kind of really scary that I find out from my pharmacist. And then at the first meeting, there was only 3 CF patients there. Nobody knew what this was. I kept calling people like, hey, have you heard of this? No. It was so quiet. It was so silent. We as patients, the burden of patient engagement is on us to let other patients know. And so we did have a big, huge involvement with them, CF patients, comparing to the other drugs that went up for review, which were Cosentyx, Stelara, Enbrel, and Genvoya. The HIV patients and the cystic fibrosis patients were the largest of the patient groups. However, they still weren't that large. We still only had about 47 patients in our group, but the other drugs were even less. So that kind of tells you people just didn't know about it. So this year they're looking at how they can change some of these. And I have heard that they're going around saying that patient engagement is better. But the facts are they're still not communicating with our major health systems in Colorado, which are UC Health, Denver Health. 2 pharmacists serve on that board. They're like the head of pharmacy. They're not just like pharmacists. They serve on Denver Health and UC Health. They serve on the PDAB board. So we reached out to UC Health and said, hey, can you make sure that the next reviews are done better and given more advance notice? They are waiting on the direction from that pharmacist that serves on the PDAB board, and she will not give it.
Wow. So they have people with expertise, but not necessarily disease specific expertise. It's not like an advisory board where they bring in sort of the
Right.
leaders of the area to make an assessment. It's
And we've
people
asked
that
for
have people that have some exposure to the medical system. What about on sort of the state government side? Do they have resources? Do they have people advising them? Do they have how are they getting insights? How are they getting data to make decisions?
Sure. So they are not getting advisement from the local legislator, the rare disease advisory committee. They were not getting advisements from them early on. They are starting to look into that more now. But the main group that they get advisement from is Portal. Portal gives large donations to ICER. So I can't make this up. That is the truth. They are very transparent about it. It's in all of their reviews. Actually, the last meeting we had last Friday, a representative from Portal presented on the IRA and the federal drug negotiations, kind of to give them an idea of how to do this. So they're asking for that advice, and that's the advice that they're going towards.
Thank you for that.
Mhm.
Got a question from the audience, and I'm so happy this question was asked because it's a perfect question to ask, and it's for both of you, I think. For PDABs, are the upper payment limits on these medications causing lower co-payments on the medications for patients at all?
No, and there's nothing in the law that requires it.
No. And I can put in the chat, Avalier actually did a study and went and blind interviewed payers or different health insurance companies. And the payers even said, this will not go back to the patients. There's nothing proving that this will go back to the patients. There hasn't been a UPL placed yet because they are taking their time to determine a UPL. So we don't really know yet how the access is going to be, but we all kind of have an idea, and even so do the insurance companies.
Yeah, so and just to kind of add on to that, so the payment limit means that it's how much basically is allowed to sort of be reimbursed, if you will, within that state. And so as we know how insurance works and with the PBMs, for example, it's access is frequently driven by rebates. Rebates are the incentives in there. And so in some ways, similar to a lot of the concerns with the Inflation Reduction Act and the Medicare negotiations, when you set that cap, does that change the incentive structure that may create more utilization management for, so more access issues, more prior authorizations, you know, more delays and hurdles that you have to deal with as a concern? Here's another question that came in, and this is, oh, we got more questions coming. This is great. My understanding is that the Colorado PDAB is trying to limit input from anyone who is not receiving or prescribing the medication being reviewed. In other words, they don't want to hear from a patient advocate or a physician or other medical experts. Is that true?
Yes, they, weirdly enough, they do not, because they are they're looping in patient advocacy organizations that receive any kind of sponsorships from pharmaceutical companies. They say they do not want to hear from them whatsoever. And if you have any tie to them, like for instance, if I went to, let's say I attended a meeting at the CF Foundation, you know, and I just went to some educational conference, and I somehow, it came out that I went to that conference, even though I don't work for that foundation, they're going to lump me in with them. So they made it clear that they said that all the letters they were receiving from patient advocacy organizations, they said they Googled each one of us. And this is what the chair said. And she blanketly said, and every single one of them receives pharma money. So we don't look at that. So they're blanketing that anybody who has any concerns about access, they are discrediting us and just saying those are pharma talking points.
And I want to take this kind of to a broader perspective as well. So, you know, other states that have sort of been notable as it relates to these boards is Oregon, which actually just recently sort of came to a decision to pause their work because they were struggling to define affordability. Maryland has really ramped up in recent months and seems to be trending towards a Colorado direction, I would say. Naomi, as we sort of look at the legislative landscape in 2025, I think, you know, do you have a sense on states that maybe, you know, big to kind of watch that will be considering this? Or will it be all states, or are there sort of pockets in the country that you know should be considered?
So I think that generally speaking, you're going to be looking at states that are bluer. And then I would also look at the federal election to see the outcome of the presidential, to see, I mean, that's going to also impact, I think, enthusiasm, depending on which way that election goes. But healthcare policy in many cases is done on a state by state basis. And so we're looking at a multi-year time horizon on the PDAB bills hitting a lot of states, and probably I would say more than half of the states at least at some point in time. And the more successful that the PDAB bills are, the more that states will embrace them. It's like a train, you know, it's going to start accelerating when there are more wins. I'm very hopeful and optimistic that the patient involvement in this particular issue has really slowed that train down and has really given pause. And I do think, you know, when you have patients who will, you know, who can tell their stories about what it will mean if they lose access, that really does have an impact. And that's why, you know, this engagement on this issue is just so incredibly important. But, you know, the combination of the Inflation Reduction Act and those, you know, and this idea that you're going to address the cost of the prescription drugs every year, a certain number, I mean, that's going to be replicated at the state level. They're going to start using those lists to guide the PDAB boards that are established going forward. So, you know, this issue isn't going away. It's going to be around for a number of years. You'll see it in different incarnations probably going forward, depending on what's happened, you know, the early success or lack of success. But you know, this is going to be around for a while.
Yeah, and I think that's an important point. And that's why I think we're talking about these boards, but we're also talking about the policy of upper payment limits as well, because upper payment limit can take form from a policy perspective in a few different ways. The one that initially I would say caught on is more of these prescription drug affordability boards. But we've seen bills introduced in Florida, for example, that is pretty aligned to what Naomi's suggesting, where rather than creating a board, you just simply do a reference price to the Medicaid negotiated product, or you consider international reference pricing as well, which is also an upper payment limit. It's just without the board. So I just think that that's something to kind of keep an eye on as well. A few more questions coming in. This is awesome. Okay. Oh, great question. Has the Colorado PDAB started focusing on premium savings versus patient savings? Do you think those will materialize?
Yes, I
Uh,
think, yeah. Go ahead, Naomi, what you think people will show up?
Oh,
Is
no,
that
you go ahead, go ahead. You're in Colorado, you're on the ground there.
Oh, okay. Yeah. So I believe that that was a bat signal sent out to people who are organizations that are run by insurance companies. Because with our stakeholder engagement meetings, we were just the patient, which actually was good. I will say that the board did give us a lot of time to talk to the staff. We didn't get to talk to the board. They will not engage with us, but we get to talk to the Division of Insurance. So we get that time, but now they're saying that anybody who's concerned about the insurance premiums or insurance premiums or their taxes, their taxpayer money going up due to these high prices of, basically patients like myself, that they're going to now be able to get into those private stakeholder engagement meetings. So yeah, we think that they're going to start showing up, and it was already hard enough to get patients to those meetings, and it's uncomfortable anyways to be putting your story out there in a public way. And you have to be really raw and talk about your patient experience, which not a lot of people are comfortable doing. So then if I was in that meeting and let's say I didn't experience this, but let's say I'm in another meeting and I had a consumer group from, AARP coming at me saying, well, how do well, you're a burden to society. So, I feel like that would be a really uncomfortable position for the patient.
Here's another question I think really teased me up and helps me segue to one of the last things I want to get into. Doctors with so this is sort of talking about the conflicts of interest, like they're unwilling to kind of talk to the doctors that have maybe pharma conflicts. Do the doctors on the PDAB have to disclose conflicts? And I'm going to add to this question: do any of the consultants to the board have to disclose their conflicts?
No, they do not. And we did bring this up, myself and other patient advocates, at this last meeting when we were going over the red lines for the new and improved PDAB for next year. It was discussed by a consumer group who represents insurance, said that we need to disclose before we even talk. Everybody should disclose where they're getting money from. So myself and another advocate said, if everybody has to disclose that, then the payers, the PBMs, and then my friend, she even said, and Arnold Ventures, and they have to disclose that as well. So we were like, that's not really fair. And so they didn't really respond to us, but they nodded their head, like the Division of Insurance, not the board, the Division of Insurance liaison, just staff director said, okay, I'll note that.
So I just want to follow on. So you recently discovered this is a great story in patient advocacy, and will become, I think, a great story in patient advocacy. I think you discovered that the board had actually been using the quality adjusted life year, potentially illegally, certainly improperly and unethically. What did you do when you discovered this, and what's going to happen?
So yeah, I was tasked with looking at our reviews and making sure that things were accurate in our reviews. And when I looked at our review, I saw ICER and Portal and Qualies mentioned about 7 or 8 times. And at this point, we hadn't seen Portal yet on any of the discussions, so I wasn't red alerted to it. But the way that they were talking about us and the way that they showed presentations about other countries, same price for our drug, and how the Qualies came up with that price, I was like, that's odd. So yes, I found out. And then in May, the 504 Rehabilitation Act actually strengthened the ban on Qualies. So that was kind of also our red light to go, okay, so anybody who's had a review after May is even more at a disposition because it was illegal. So we were able to basically put them on notice and state, so we've been sending them letters for a long time, myself and other advocates and other organizations, that it's not right to be using qualies. And so they know it. But now we went ahead and we consulted with a healthcare attorney, and he was like, you're absolutely right. It is illegal and you're onto something, and it's wrong. It's blatantly wrong, because the statute in the PDAB law says they cannot use qualies to determine a UPL. But the loophole was they can use them for the review. So our organization and our attorney, he's like, that doesn't make any sense. You can't use something in a review and use that data from that review, and you're taking this data and you're giving it to the board to come up with a UPL. You can't unring that bell. You can't say, okay, you know what? Don't look at that stuff that big report we just gave you, because just kidding, those are illegal. So just, get those out of your memory, basically. So yeah, so basically that's the next step. Is we don't feel that contracting with ICER or Portal is appropriate. Contracting with Portal, because those are not appropriate values, and that's the only people they contract with. So it's illegal. It's literally illegal. And I thought maybe the federal ban would have to go through first, which thank you so much, because I found out that Patients Rising is, really active in this space. But it doesn't even have to do that, because the 504 disability law reinforced and strengthened this ban on top of that. Now, yes, I believe we're going to have a full quality ban to really press the issue. And so we are working on that in Colorado. 2 states that have already had a quality ban are Oregon and Oklahoma. So they actually have a quality ban. They have some awesome advocates there that got that big mission done. And so, yeah, it doesn't make sense to me that we're even having to do this on a state level. If it's banned through Medicare, it should be banned through a UPL process that affects Medicaid. But I guess we're going to have to take it further and get those quality bans even more strengthened in the states.
I got to wrap, but I see Peter has a question, so we'll take one last question from Peter, and then we'll.
Thanks, MacKay. Just quickly, Amanda, when people ask you to talk about your conflicts, you definitely should ask them to talk about their conflicts. And the biggest conflict is accepting money from the government. Because the government is the payer, they are the ones running the hearings. If you're taking government money, that is a conflict.
Right. And the people who are doing these meetings work for the Commission of Insurance, the Division of Insurance.
How about that?
All right. Well, Naomi, Amanda, I appreciate you both for your time, and thank you for sharing your expertise. Amanda, thank you for sharing your story with us. We really appreciate it. And thanks everybody for the questions. We're going to move on to our final panel. I'm going to send it back to Terry, and we'll talk a little bit about charity care. I think you're on mute.
Thank you, MacKay. This is one of my favorite topics as of late, and I apologize that we are actually supposed to be done right now, and we're just now starting. So
we're on time.
we are?
Yeah, we're good.
Okay. I don't know. I thought we were supposed to be only an hour. Okay, sorry. That's my fault then. Okay, this is one of my favorite topics as of late, which is access and affordability and charity care per se. We have a fantastic panel of experts who are going to shed some light on the realities of charity care and medical debt and explore how reform efforts, including those related to the 340B program, can improve patient outcomes. So I'm excited to introduce our panelists. First, we have Demi, who is I want to start by saying Demi Montgomery is the president of our Patient Senate. She's also a member of our board. She's an advocate who has firsthand experience navigating the complex charity care system and represents the voices of patients in need. So thank you, Demi, for joining us. And next we have Eli from one of our partners, $4, which is an organization that has been at the forefront of helping patients eliminate medical debt through charity care, exposing the flaws and abuses in the system. So welcome. And then we have MacKay. So to kick it off today, Demi, what are the specific barriers patients face when trying to access charity care programs? And how do these barriers disproportionately affect certain populations? And how do you think healthcare providers could better facilitate access to these programs?
Oh, thank you, Terry, for having me. So the main problem and the main issue that I'm seeing and hearing, and that I've experienced myself, is that we don't even know about charity care. Coming through the door, we're not explained that charity care even exists. So we are told that we have to pay for the services, but then we're not told that there's assistance program for us. So the fact that there's no even knowledge or information given about charity care is a huge barrier for patients just in general. And then we are also seeing that it when they do find out that there's charity care, there's time limits on that. So sometimes you don't find out for a long period of time, and then by the time you're able to apply, you don't qualify. This is really causing major issues. And then there's also another problem that I really have noticed, and it's the mental health issues that are being created by these financial burdens, that the patients that are already suffering from some sort of condition are coming up with from having these financial burdens put on top of that. So it's actually creating a whole new circle of people that have mental health issues behind the stress and all of the navigating of the systems. It's really becoming a huge issue and a major problem.
Well, thank you for that. Yeah, one of the things that we have been talking a lot about lately are patients' rights to, the patient's right to know about these charity care programs. They don't even know if they can apply for charity care, which leads me to my next question with Eli from $4. So Eli, $4 has done an amazing amount of work bringing attention to medical debt elimination through charity care. Now, can you share with us a story or example that illustrates we just heard Demi talk about it from her experience, an example that illustrates the failures of the system and how $4 has intervened to correct these injustices?
Yeah, I have some stats that I pulled from some research that we published earlier this year that actually just backs up everything that Demi just said. So I want to run through those, and then I can kind of give some real world examples for how this stuff plays out, at least from what we see. We tried to figure out the size of the ungranted charity care problem, how many patients are actually falling through the gaps. The number that we came to that we're estimating is there's at least 14 billion a year in ungranted charity care. This isn't revenue to hospitals. Most of this ends up as bad debt, and people end up declaring bankruptcy or on debt collection dockets or whatever. And in survey that we did, we found that only 29% of eligible people who, or people who actually get charity care, of the people who are eligible for it. So this is not making its way into the hands of about 70% of people who are eligible. We think about charity care policy in kind of three main buckets. Is charity care known to patients? Is it easy to access by patients? And is it administered in a fair way? So is it known, easy, and fair? And honestly, my stats are right in line with what Demi just said. In the known bucket, we found that 65% of patients who didn't apply but were eligible that said that they just didn't know that the program existed. That was by far the number one reason for why patients didn't apply. 52% of all patients, regardless of whether they did or didn't apply, reported that the hospital never told them about charity care. They didn't get any information about it. In the easy bucket, our responses said that a quarter of patients reported that the application process was either hard or very hard, and 14% of applicants never received a response from the hospital, either approving or denying them. It just went into the void, which is pretty consistent with what we say. We usually have to submit an application 3 or 4 times to actually get an approval. And then in the fair bucket, the biggest stats that jumped out to us were the dramatic inequities amongst racial groups. So Black patients have a 62% lower probability of being approved for charity care across the board. That was pretty consistent wherever we looked. And about half of all denials are because, exactly like Demi said, it's either the age of the bill or they claim paperwork issues. And so real world scenario, we might see something like this play out is for what we might call like an abuse, is a lot of hospitals will be very vocal about the use of like a presumptive eligibility tool. They invest in these big data tools like Experian Health or FinThrive or something that are supposed to gobble up a bunch of data from credit report databases and then estimate a patient's household size and household income. And hospitals will tell regulators and they'll brag about, we're screening everyone with a presumptive eligibility tool. When you dig into their policies, what they don't say is the vast majority of them bill on day 180 after they've billed, or they screen patients on day 180 after they've billed the patient. So they send them the bill, like Debbie said, they tell them you owe this amount. They don't tell them anything about charity care, or at least not in a way that is like meaningfully communicating anything to them. They send them through 6 months of the billing process, and then right before they send them to a debt collector, they might screen them. There's a case going on in Oregon right now against a major hospital system who did exactly that. Screened the patient on day 180, found out that the results indicated that they were eligible for 100% charity care, and then sent them to collections anyways. And that person ended up being garnished, I believe. So like that's just a pretty, like, this isn't it's not an outlier. This is just how these programs are largely administered. Hospitals will quibble with me if I say that. All of them think that they're doing this well. None of them are doing this well. Another example of an extremely common thing that I would call like an abuse of the law is there's a 240-day application period under federal law from the date that the patient has sent their first post-discharge bill. Most hospitals will say if you submit an incomplete application, which they define because they'll claim that they need some other, maybe you submitted your tax return, but they also want 3 months of bank statements to prove that you're not hiding $1 million inheritance or something, which they think happens all the time. Then they'll say you have 30 days to supplement your application to complete it, to provide these bank statements. The patient might still have 200 days left in their application period, but if they don't supplement that application within 30 days, the hospital will then deny them for missing that arbitrary deadline that they set, even though they still have this entire like application period that's wide open. There's just, I mean, I could go on and on of these like individual examples because the way that these programs fail is really death by 1,000 cuts. But the long and the short of it is they're just not working, and everything Demi said for the patient experience is exactly what we see.
That's amazing. What's the overall, I mean, is there a charity care sort of, is there a rating standard for what most hospitals do for charity care in your world? And I know we talk, I can talk about it from sort of a 340B charity care standpoint, you know, what 340B programs are doing, but is there a level in charity care that you think would be, you know, acceptable that the hospital should be trying to meet?
It's really tough. The Lown Institute's published some good stuff on this with their hospital price index or their community benefit index or whatever it's called. I think that that's a little bit of a, even though I like the work that they've done and I think they're leading the way on trying to set that standard, it's a little bit of a blunt tool for the job. I am sympathetic to some arguments hospitals will make. For example, if they live in an area with a really high Medicaid eligible population, it makes sense that they might have a lower charity care percentage when you calculate as a percentage of revenue or something. Same for children's hospitals, kind of because of the Medicaid thing. There's going to be more kids that the Medicaid eligibility is expanded. So there are scenarios where I don't know that you can necessarily there's some apples and oranges. And I think, I guess short answer is I'm not aware of anything that I think really sizes that up with like specificity. And then the only, I guess, ranking system to my knowledge is what the Lown Institute has put out.
Okay, MacKay, I just mentioned 340B without defining it. Can you do that for us?
Yeah, sure. So as Eli was sort of talking about, so nonprofit hospitals are expected to offer charity care. Is sort of something that went through the IRS, but it's a pretty nebulous definition, which I think it results in some of the challenges that um, both Eli and Demi described. But there's an interesting financial mechanism as well, that's a little bit obscure and a little bit less known, but incredibly important. It's called 340B. Why it's called 340B is because that's Section 340B of the Public Health Services Act. And really, what this was, it was originally passed in 1992, and the idea was that pharmaceutical companies would offer drug discounts to um, hospitals, like specific hospitals and clinics that um, qualified under certain criteria, and they would get discounts, drug discounts, let's say 50% off. And they would be or the opportunity then would be they would charge the same price or software. Let's make the math simple. They'd charge $100, though they'd pay $50 for the drug. That margin that they'd make on that drug, the intent of that was to help bolster charity care, help support and expand existing resources. It's a federal program. And what's happened over time is we've seen a pretty substantial amount of expansion. I just want to point out too, it's governed because a lot of these are terms and agencies that we don't frequently talk about. And so this program is managed under the Health Resource and Services Administration, also called HRSA. And just to level set, it's historically known for pretty poor oversight, this program. There's been several government accountability reports, GAO reports, that has said that's too reliant on hospitals sort of self-governing, if you will, that the guidance that's been put out is not specific enough, not clear enough. And this goes back for decades. This is not new information. And today, roughly about a third of the hospitals are these covered entities, these 340B entities. Now, here's the amazing thing. HRSA just put out some numbers recently for 2023. The 340B program, the spending on 340B drugs was $66.3 billion. $66.3 billion, okay? And remember, the full intent of this program is to create resources so that hospitals and some community service centers can invest in charity care. Okay. To give you some additional context, that's up 23% from the previous year. And to give you a little more context, in 2014, this program was $9 billion. That's substantial growth. The largest drug in the in the 340B program is a cancer drug. I'm not going to get into brands, but the U.S. sales, and all of this is on the HRSA website. The U.S. sales for that drug were $15 billion. 45% of it went to 340B. All right, so that means that the 340B spend was just about $7 billion. Okay, just on one drug alone. That's a substantial amount of money. That and the challenge is, the concern is around the accountability and where that money is actually going. There's a New York Times article that was it's a few years old now, but it talked about a hospital system in Richmond, Virginia. I encourage everybody to check this out. And there was a specific hospital called Richmond Community Hospital, which served a poor and predominantly Black neighborhood in Richmond. And the article basically got into the fact that it was a 340B hospital, but the parent hospital was basically profiting off of all of it and investing those resources into the wealthier areas or the high profit centers of the larger hospital system. Now, that's clearly a bad actor. We do believe that there are 340B entities that are good actors that operate well. I don't want to paint broad brushes, but it is a concern because the spirit of the program is not meeting its original intent anymore. And let's talk about why. Okay, so when the Affordable Care Act was passed in 2010, what happened was it allowed these hospitals these covered entities to operate with what's called more than one contract pharmacy. And this is where it gets interesting, because these contract pharmacies, guess who they are? They're our good old friends at CVS and Walgreens and Sigma. They control about 75% of the market. Okay. And the bottom line is we've seen dramatic expansion of these contract pharmacies ever since 2010. There's a lot of reasons for it that we probably don't have time to get into today, but one of the concerning trends is that that you can see there's probably 6 of these contract pharmacies in the some of the wealthiest zip codes in the country, and 0 in the poorest zip codes in the country, just to give you some context. And just to give you a little bit more, it's becoming such a financial opportunity for particularly these pharmacies, the PBMs, that and their parent companies, that they're actually having to talk about these things on earnings calls, that if there's impacts to the 340B program, it can be hundreds of millions of dollars as it relates to profit. And so I think the biggest concern is this is charity care gone bad, right? It's become too much of an opportunity where it's big business and less emphasis on the charity care. I'm all about everybody making a buck. I totally get that, but the problem is you cannot rob Peter to pay Paul, and we really want to focus on getting this back to what its core purpose was, which was to serve people in need.
Thank you. Demi, I'm going to come back to you for a minute. So many hospitals claim to provide charity care, as we've discussed, and Eli has let us know. But patients often aren't aware of the programs that are available to them. Another thing we have also discussed. Do you think hospitals should have a legal responsibility to proactively disclose these options for patients?
Yes, Terry, I was sitting here thinking that I would think that my suggestion would be that when they give you your patient's rights, that they should also be required to give you information on charity care at that moment. At that point, they should be forced to explain to you what charity care and that it's an option available to you, especially if they see that you don't have the type of insurance that covers all of your medical needs. So I really think that it's unfortunate that it's a hidden secret and it's causing patients so much pain along with that. So I do think that, Terry, I think that should be their responsibility. If they have to be forced to legally, then I feel like that should be done.
Yeah, I find that this is the real story here around the 340B aspect of that those funds being supposed to, a portion of them, not all obviously, but being used for charity care. And patients just simply not even knowing or being aware or having any idea. People ask all the time, do you guys have 340B stories? I'm like, no, because patients don't have 340B stories because they don't know about 340B. So it's very, I think that's where the charity care tie often is for me. It's like, where is the, patients should know. To my next question, Demi, should patients be informed if they're classified as 340B patients, especially given the revenue hospitals can generate from that classification?
Oh, yes, they should definitely know, especially in the BIPOC communities. I feel like explanation should be given too. They should also be explaining exactly what 340B is and how it can affect them and how the hospital is actually managing the money. The transparency should be there just in general. But I really think that in underserved communities, it is a major problem there. Because like I said, I'm very transparent about myself. I live in an underserved community and we are not seeing that where I live. We do not know about it here. It is not talked about here. It's not shared with us. And I feel like I'm not the only area that's dealing with this concern. So I feel that they should be obligated to, and they should definitely be sharing all information surrounding this subject.
I agree. I think we had some patient advocates like yourself a couple of weeks ago sitting down with legislators and talking about, they were the legislators, state legislators were learning simultaneously with the patients about the 340B program And the patients were simply telling their story, like you, Demi, of being in the hospital and not being able to get any charity care or even know anything about it, and clearly being in need of it. And I won't go into those stories because now that I know we had an hour and a half, this whole time I thought we had an hour, but still, we only have 9 minutes left, and I want to keep to that because you guys have been great. So Eli, I want to come back to you on this. So as you've worked with state legislatures on charity care reform, what do you believe are the key factors for success in states, the specific states that you guys are working in, leading the way on this?
Yeah, so there's two kind of philosophical approaches to charity care policy that some states are addressing. The big one is we're actually trying to go a step further than trying to advocate for more robust notice requirements. We want to shift the whole approach to the policies, and some states are doing this. Oregon recently did this, to remove the focus on getting patients to apply and focus it on getting hospitals to screen. So even like removing the application requirement, full stop, like everybody just gets screened for charity care, and Medicaid and like any of these other means tested programs. That should just happen at the point of service, and there should be better systems in place to accommodate that. And there's like a whole can of worms that comes with how that would be accomplished, but we think it can be accomplished. We think it's very, very doable. And so that's one big thing that states are doing that is completely left out of the federal law. And two is states are often treating their policy as I think what it should be, which is a consumer protection statute. And federally, this is just something that is sort of a kind of like a quirky thing in the tax code. This is something that nonprofits have to do as part of their community benefit to be a nonprofit. And so because it's in the tax code for a lot of like in the weeds legal reasons, there's really no standing to sue for violations of it. The only body that can enforce these laws is the IRS, which they've shown they're not very interested in doing. And then the IRS doesn't have very good remedies available in the statute. By and large, there's some instances where they could tax some of this income, but by and large, all they would be able to do is pull a hospital's nonprofit status. So the fact that it's such a drastic remedy by a body that has the least capacity to do it, and you can't file a lawsuit or class action lawsuit or false claims act suit or one of the many other tools you would use for enforcement outside of the public agency doing it, just means that the federal law just doesn't get enforced. So most states who have passed a law have multiple state level agencies who can enforce it, usually the Department of Health and the Attorney General's office, because it's treated like a consumer protection statute. And then there's often a private right of action. So actual patients can use it as a sword instead of just having a shield, maybe in a debt collection lawsuit, or they could put a class action together to enforce the law against a particularly bad actor. So those are the two big things, I think, at a very high level that states are starting to get right, where the feds have missed out on.
We actually have a question for Eli from the audience. What strategies do your advocates follow to enforce a hospital charity care's obligation for a patient?
It's just raw advocacy. I mean, we have incredible patient advocates. We do training on this stuff. We have a bunch of like template letters, but they just know the rules inside and out, and they call and pester a hospital until they do the right thing. It's just a war of attrition.
Great. That's it. I was looking to say, is there another one, MacKay?
There is 340B only available to nonprofit hospitals?
Oh, yeah. It is. Yeah, you can take it, MacKay.
So mostly yes, almost all. There are some, but they would be basically government, state, or local government institutions that might also be eligible as well.
Right. And then there's the 340B eligible hospitals, and then there's the 330 guarantees, like the Ryan White clinics and those which are separate. And those clinics, for some reason, have no trouble doing quarterly reporting on what they do with their money. So it's amazing. Isn't that amazing how that works? And hospitals seem to think that would be really complicated. So
Yeah, and and I probably should have clarified too. So not just because you're a nonprofit hospital doesn't mean that you become a 340B hospital. There's some additional criteria, like you're dealing with disproportionately impacted neighborhood. There's some other criteria that goes along with it. Children's hospital, critical access hospitals, things like that.
before we wrap this up, Eli, I want to come back to you really quickly on the state legislative stuff you just spoke on. Are there key state, or have you passed any in any of the states? Number one, is anything passed, or do you have model legislation that you're working with in states? I have a lot of advocates on here from our graduates from our legislative advocacy masterclass and such, and I would just sort of love them to get a landscape of sort of what states might be looking at this in 2025.
Yeah, I think the closest to hitting the nail on the head is the Oregon law, chiefly because they have a pre-screening requirement that basically every patient must go through. And we're working like boots on the ground in Oregon, kind of with a lot of hospitals now, trying to help them comply and figure out the best way to do it. So we're still working out kinks. And we are just getting to a point where we think we're starting to see the forest through the trees on what we think like model policy should look like. We've spent a couple of years now just in the trenches with patients, working through these things and living this experience with them. So we will be publishing a lot of things on our website throughout the rest of the year, and probably for like the first quarter of next year. So there is a lot of that to come that's in the works right now.
That's great. We'll be sure to share that in our community with the advocates. I know they'll want to follow that for sure. As we wrap up, do the three of you on my panel, Demi, Eli, MacKay, do you have any final thoughts on this issue on 340B, charity care? Anything you want to put about?
Yeah, I think I just want to mention real quickly too, why is a federal program being brought up on a state issue? Well, I'll just be real quick, and I think we intend to talk to our patient community a lot more about this issue later this year. But several states, including Michigan right now, are looking to effectively codify these contract pharmacies into law. And I don't want to say the spirit's wrong, because I understand why they're doing it, but the challenges and the dynamics of drug pricing make it, I think, a little bit concerning that this would be the approach that they would take. The spirit is my understanding is there's rural hospitals, there's hospitals that are really struggling out there that would benefit greatly from more access to 340B funds. And this kind of ties to my final thought. That's right. I mean, there are 340B funds should be going towards those communities, those hospitals in those communities of need. The real question we need to answer, though, is why is it not effectively today? And that really starts, I think, number one, with some transparency. Number two, with some clear standards and definitions on what are charity care. And number three, accountability for what those standards are as well. Demi?
I would like to say that I think that the people that aren't already a part of the Patient Senate consider becoming part of the Patient Senate. We will be following all these efforts and participating as much as we can. And hopefully we can be a part of making a difference in the change that's coming.
Great. Thank you, Eli. Any final?
I doubt that there are any hospital executives in the audience, but if there are, I always want to extend an olive branch, because we can be pretty critical of hospitals, I think, for good reason. But at the same time, I actually don't think we are that far apart and might even be totally aligned on this issue. We all want what's best for patients. Nobody wants to bankrupt patients. I push every hospital executive I can get in front of to the extent they can, look at their books and actually see how much money they're collecting from charity care eligible patients that they send through their billing process. Because I doubt it's a profitable endeavor. And I think that if they open their minds that 100% charity care grants would not negatively impact their revenue and would only remove the cause of the number one cause of bankruptcy in the country, that this could really be a win-win policy for both the patients and the hospitals. So I want to put that out into the ether, that we're not necessarily against the hospitals all the time, but if they see the light of day, then we're on the same team.
Oh, I couldn't agree with you more. I mean, the hospitals are a huge part of many communities, and especially when we start talking about rural communities or communities where the hospital is, the only game in town. And I'm actually from a part of Arkansas, where my grandmother was, that only had one hospital, and it was 20 miles away from my grandmother. I mean, it served an entire region of people, and those hospitals need these dollars when we're talking about 340B, and they do provide an enormous amount of charity care. But how can we look at that to make it less cumbersome for not only them, but for especially the patients themselves? And to MacKay's point, when we're talking about 340B and we're talking about a patient's right to know these things, he's talking about what's going on in the States, and I'm not going to get into that anymore right now. But what I will say is what he's talking about, which sounds a little wonky, is actually one of the things that they can sort of push through, because patients don't know a lot about 340B. And that's one of our goals at Patients Rising over this next year. And as we enter the next set of legislative sessions, we believe patients do have a right to know, not only about the charity care and the processes that Eli's talking about at $4, but also about if they're tagged, a 340B patient, and they're making money for the hospital while simultaneously getting like bill collection sent after them, all sorts of things. Patients have a right to know that. And so we're going to be delivering a lot more information about that as we enter the next year. And I've gone over 3 minutes. I apologize. And I also apologize to MacKay for thinking that we were only an hour. I apologize in front of everybody.
No, we
I haven't done an hour and a half. I haven't done an hour and a half one before. I was like,
we would typically like to keep it to an hour, but this one was so packed with people and policy that an hour just was never going to be enough. But
well,
thank
you.
thanks everybody for attending. But wait, there's more. I meant to announce this earlier. I want to let everybody know we are launching, as part of our masterclass, a new program focused on prescription drug affordability boards and upper payment limits. And it's available for new members taking the class, and it's available for graduates as well. We encourage everybody to do so, because we think this is going to be an issue that's going to be relevant in just about every state, frankly. And so if you want to know more, feel free to email us, contact us on Circle. I believe Jim is working on making a space on Circle specifically for this, so everybody is aware. But please check out that class. We would really appreciate it and would love to get your feedback. And we'd love to get your feedback on this town hall. This is our second one. Again, it was a little bit longer, and I do apologize for that. But again, it was so much, we just couldn't fit it in an hour. But continue to get your feedback on ideas. How do you like these forums? How does it work? We want to serve you guys with the best information, and at the end of the day, all march forward in trying to pass patient-inspired health policy. So with that, I will say good night. Thank you to our speakers, and I hope we talk again soon.
Thank you, everyone.